Turning then to the Canadian Nurses Association, Mr. Villeneuve.
Thank you, Mr. Chair and members. My name is Mike Villeneuve. I'm the CEO of the Canadian Nurses Association. I've been an RN for the past 35 years and worked for 40 years in the healthcare system in a couple of other roles. I'd like to thank the Standing Committee on Finance for the opportunity to present recommendations from CNA, which is the national and global professional voice of registered nursing, representing 139,000 registered nurses and nurse practitioners across Canada. Our submission highlighted 4 recommendations, but I'd like to focus on 2 of them today. Our first recommendation calls for the creation of a healthcare innovation agency for Canada. CNA believes that the federal government has an opportunity to build on what it has already achieved with its provincial and territorial counterparts by facilitating new opportunities for healthcare innovation across Canada. We see the spark, so there are some successful innovations right across the country, but there's little mechanism to help spread and scale them up. A new federal agency would target funding on innovative healthcare projects to ensure that they're adopted more widely for everyone in Canada, including Indigenous peoples wherever they live. The new agency, for example, could lead efforts to evolve Medicare to help overcome the sometimes fragmented nature of our healthcare system. To drive the notion of the right care provided by the right provider, the right time, the right place, and delivered at costs we can all bear, the kinds of innovations that we need should accelerate the dehospitalization of health systems, not unlike what you just heard from the Canadian Medical Association president. Nurses work at all points in health systems, and we recommend that nurses have a strong leadership role in any such new agency. There's nearly 428,000 regulated nurses across Canada, and we're well poised to dig in and to help. The second recommendation I'd like to highlight today and encourage the committee to support is the third one in our submission, which is around improving access to palliative care and support for people in Canada who are acting as caregivers. I'm pleased to inform the committee that CNA is a member of the Quality End of Life Coalition of Canada, and I serve as co-chair of a committee of the National Network, along with 38 other national organizations whose vision is that all Canadians have the right to quality end-of-life care that allows them to die with dignity, free of pain, surrounded by loved ones, and in the setting of their choice. Most Canadians tell us that they want that kind of care, and we know they could benefit from it. Better palliation drives down costs. Most Canadians never receive that care. The challenges we face in palliative care are compounded by our country's aging demographics, as we're set to become one of 13 super aging nations by 2020, which is 18 months from now, I always remind people. And nearly 1 in 4 Canadians will be over 65 by 2031. We recommend that the framework for palliative care in Canada, which was passed into law in December 2017, must include targeted federal investments for both new and existing federal programs to improve standardization of delivery of palliative care for people across Canada. We were happy to support Bill C-277, tabled by the Shadow Minister of Health, and we acted strongly to help that move along. New federal funding that's predictable and sustained would help to address the gaps that currently exist in palliative care across Canada. We're pleased that the framework recognizes the palliative care training and education needs of health providers as well as other caregivers, and we urge the committee to support our recommendation to provide funding for early career access to palliative care training and education to nurses and all other healthcare providers. Research tells us that our country does not have adequate palliative care training for healthcare providers. One way to address the gap is to include education and training in core curricula for students, but also to create structures to provide that education soon after licensure. We're also calling on the federal government to provide increased financial support for the country's 8.1 million caregivers by making the former family caregiver tax credit, which is now under the new Canada Caregiver Credit, refundable, and extending the compassionate care benefit programs to include a 2-week period of bereavement. In its current form, the tax credit is not paid to recipients as a direct cash benefit, and while we support the drive to move care out of hospitals, we've also pushed significant costs out to ordinary people. Many caregivers face high out-of-pocket expenses for specialized medical aids, medications, transportation, hiring staff, lost wages, and so on. A refundable tax credit could help ensure that all eligible households receive something in return for those kinds of expenditures of time and money. Regarding the CCB, CNA believes that adding a 2-week period for time for bereavement would allow flexibility for caregivers, many of whom are employed after a patient's death. Such a measure also allows for a more reflective and humane palliative care process. Currently, support that's provided for successful applicants only covers the caregiving period for up to 26 weeks and not for bereavement. Adding that 2-week bereavement period would surely provide caregivers with some important financial support after such a profound loss. Thank you for hearing our ideas, and I look forward to our conversation.
What are the things your organization can do and do well, either for modest requests of government, or not just the federal government, but perhaps the provincial and municipal governments, if you do work with them, or do without funding, but something else that government supports could give you?
It's a little hard to get our hands on 428,000 RNs and nurses in all categories and where they work, because they're all through the system. So how do you do something simply with that is tough. But let me give you one example when we talk about innovation. At Toronto Western Hospital in Toronto, they discovered that they had an awful lot of admissions of older folks transferred in from nursing homes. And we know that every time we transfer an older person, they're never quite the same after. They never recover the same way we would, and the older you get, the more of a problem it is. So they undertook an initiative to see if they could reduce the number of transfers by sending nurses out from the emergency room to those places rather than bringing the people in. 1-year trial, 80% reduction in the number of people being transferred. Huge implications for those people, for the costs. A nurse going out. So, how could governments help? Someone needs to send the nurse out. Someone needs to pay for the cab to send the person out there. When I got sick in London last year, London, England, I did what you always do. I Googled, what do you do when you're dying in London? And it said, go to this place. So I go to a clinic, and first of all, they didn't ask any information, just my name. Didn't want any money. Didn't want to charge me for the drugs. So that was the whole thing. But it was run entirely by nurses. 7 nurses, 200 patients a day, triage you within 3 minutes, out the door in 2 hours. Not affiliated with a doctor or a hospital. Nurse-run clinics. So your question, how could we work with governments? To set those things up, we're ready. We have nurse practitioner workforce across the country, a registered nurse workforce. We just need some help to make it happen, to move it. There has to be a place for them to go. They have to be regulated to be able to do that. But I think we're ready to jump on some of those for a fairly reasonable cost.